Yes, perfect.
Perfect. Thank you so much. Thank you again for the invitation to present this webinar today on salivary gland-like tumors of the breast. This is one of my very favorite topics in breast pathology in general, and one of my favorite topics to speak about as well. So I feel very privileged to be here today. So the breast and salivary glands, in many ways, embryologically and histogenetically, are quite similar. They're both derived from ectoderm. They both are comprised of tubuloacinar exocrine glands with progenitor cells that can differentiate into both epithelial and myoepithelial cells. And so perhaps it should be no big surprise to us that these glands can develop tumor types with similar features. This is a list of the WHO classification of tumors that can arise in the salivary gland. You can see it's a very extensive list of tumors, but in fact, there's only a very relatively small number of salivary gland type tumors that, at least that we recognize, to arise in the breast. The WHO classifies these as actinic cell carcinoma, adenoid cystic carcinoma, secretory carcinoma, and mucoepidermoid carcinoma. In the current WHO classification, they also have included polymorphous adenocarcinoma, but this is an exceedingly rare tumor with only isolated case reports in the literature, and so I won't discuss that tumor here today. Pleomorphic adenoma in the breast is, in the WHO classification, is discussed in a separate chapter on epithelial and myoepithelial tumors. And adenomyoepitheliomas, both benign and malignant in the breast, are sometimes also considered to be salivary gland type tumors. Also in the WHO classification, listed in a separate chapter on epithelial myoepithelial tumors. Now, there's no named adenomyoepithelioma in the salivary gland per se, but it's, I think, generally recognized that these tumors share significant morphologic overlap, as well as, in some cases, genetic overlap with epithelial myoepithelial carcinomas in the salivary gland. Regardless, due to time constraints, I won't be able to discuss adenomyoepitheliomas here today. It's also interesting that tall cell carcinomas with reverse polarity share hotspot mutations in a gene called IDH2 with a rare tumor in the salivary gland called striated duct adenoma. And so although these tumors might share some cytologic similarities, it's currently unknown if these tumors are actually different morphologic patterns of the same tumor type, meaning that tall cell carcinoma with reverse polarity might be a salivary type gland type tumor, or are these just independent parallel genetic events driving these tumors? So I won't discuss tall cell carcinomas here actually at all today either. I think it does bear mentioning that actinic cell carcinoma in the breast is probably better referred to as actinic cell-like carcinoma, or perhaps breast carcinoma resembling actinic cell carcinoma, because these tumors do morphologically resemble actinic cell carcinomas in the salivary gland, but have been shown to be genetically distinct and probably are different tumor types. Now, salivary gland-like tumors in the breast do share with their salivary gland counterparts similar histomorphology, similar immunoprofile, and in many cases, similar genetics, again, excluding actinic cell-like carcinoma. But there are also some key differences in some cases. For instance, the relative incidence of these tumors. Mucoepidermoid carcinomas and pleomorphic adenomas are some of the most common tumors in the salivary gland, but are exceedingly rare in the breast, for instance. Also, with respect to precursor lesions, most salivary gland-like carcinomas in the breast can be associated not infrequently with an in situ component. This is not generally considered in the salivary gland for these tumors. And the behavior and treatment of these tumors may also differ, most notably, for instance, adenoid cystic carcinoma. These tumors can be diagnostically challenging, in large part because they're rare, so there's limited experience among many pathologists for any given tumor type. They're morphologically diverse. They show a lot of histologic and immunophenotypic overlap, both between themselves, among other salivary gland-like tumors, as well as with other benign and malignant tumors that can arise in the breast. And the truth is that some of these tumors simply cannot be readily classified into any categories that we currently recognize. And this is always a diagnostic challenge when it does arise. Nonetheless, a lot of these tumors have characteristic molecular features that can help facilitate the diagnosis. And in fact, when we think about tumors in the breast with genotype-phenotype correlation, I've listed here, there's a significant enrichment for salivary gland-like tumors. As you can see, these are highlighted here in light blue. And so I'll discuss most of these tumors one by one in this lecture, again, with the exception of adenomyoepithelioma. I think it also bears mentioning that in some cases, we now have immunohistochemical markers or even RNA in situ markers that can serve as surrogates for these genetic aberrations and can also be diagnostically useful in that sense. There are broad clinical implications for the diagnosis of these tumors. For tumors that are benign, like pleomorphic adenoma, that have low malignant potential, like adenomyoepithelioma, they should be distinguished from other benign lesions due to a risk of local recurrence, and in some cases can also undergo malignant transformation. Salivary gland-like carcinomas are interesting in that they're often triple negative, but have indolent clinical behavior in most cases, and so need to be distinguished from other triple negative breast cancers, especially to avoid overtreatment. On the other hand, there are rare cases with high-grade features and also rare aggressive subtypes, such as, for instance, solid basaloid adenoid cystic carcinoma, that will require more aggressive treatment, and patients can also be candidates for targeted therapies in some cases. And lastly, I think it again bears mentioning that, in addition to limited pathologist experience, clinicians also have limited experience with these tumors and often struggle with how best to treat these patients, given that there's no established guidelines. All right, so pleomorphic adenomas, of course, are the most frequent tumor in salivary glands, but again, are very rare in the breast. They're composed, like in salivary gland, of epithelial and myoepithelial elements in a characteristic chondromyxoid stroma. And they also share genetic features with their salivary gland counterparts. In the breast, there's very limited epidemiologic data for these tumors. They usually arise in adult women, often retroareolar in location. On imaging can mimic other benign lesions like fibroadenoma. Because they tend to be, and they should be very well circumscribed, as you can see here. There should be no infiltration to the adjacent tissue. Sometimes they have lobulated margins. And you can appreciate here in this low power image of this pleomorphic adenoma, the variable kind of architectural growth patterns throughout the tumor, which give this tumor its name. These tumors are composed of glandular structures, either nested structures or tubules of epithelial and myoepithelial cells, again in a very characteristic, usually chondromyxoid stroma. Oftentimes there's also oval, stellate, or spindled cells within the chondromyxoid matrix that can be present either singly or as in strands. And very importantly, these tumors have no atypia, necrosis, or significant mitotic activity, and certainly no atypical mitotic activity in order to make this diagnosis. Here's some examples of the typical stroma being either chondromyxoid in most cases. Most tumors also have areas that are more fibrous in appearance, and rarely you can also see frank cartilage and bone formation as well. The epithelial component sometimes can show hyperplasia, usual type ductal hyperplasia, and in some cases also really metaplasia. Here we have an example of sebaceous-like metaplasia at the top of the screen, and on the bottom we see an area of apocrine metaplasia. By immunohistochemistry, of course, these tumors have epithelial and myoepithelial elements that can be highlighted with the appropriate markers. The myoepithelial cells typically express myoepithelial markers P63, SMA, SMM, opponent, but I think should be mentioned that these markers in some cases can be attenuated. For instance, if we look at the P63 stain here on the bottom left, in some cases, glands can be entirely negative for one or more of these markers. And I think highlights the importance of using a panel of myoepithelial markers in these cases, as we always do in the breast, in order to not misdiagnose this as an invasive carcinoma. The epithelial cells are positive for low molecular weight keratins and are ER positive. Now, genetically in the salivary gland, pleomorphic adenomas often harbor rearrangements in PLAG1 and HMGA2 genes. These have also been identified in carcinomas arising from pleomorphic adenomas, and the rearrangements are thought to upregulate the PLAG1 and HMGA2 proteins, and this in the salivary gland can be diagnostically useful by immunohistochemistry to detect overexpression of these proteins. On the other hand, in the breast, there's actually very limited data on molecular analysis of pleomorphic adenomas, but the few cases that have been so far reported have shown rearrangements in two instances of PLAG1, including the same translocation that's been described in the salivary gland, as well as one case with a rearrangement of HMGA2, again, with the same fusion that's been described in the salivary gland. And so far, there have been very few carcinomas arising in PA that in general have been described in the breast. But in terms of molecular analysis, only two of these have been reported, and so far no arrangements have been identified in those cases. Of course, the most important differential diagnosis of pleomorphic adenoma is going to be matrix-producing metaplastic carcinoma, given the prominent chondromyxoid matrix of these tumors. Both of these tumor types are often circumscribed, can have a pushing border, and of course, the key distinguishing feature then is the absence of atypia, significant mitotic activity or necrosis in a pleomorphic adenoma. Also, typically, metaplastic carcinomas lack the characteristic organized biphasic epithelial myoepithelial pattern that's seen in pleomorphic adenomas, at least focally. One marker that also might be very helpful in this differential in some cases is P53. Most metaplastic carcinomas with chondroid differentiation do have P53 mutations and will show an aberrant immunohistochemical staining pattern for P53, whereas pleomorphic adenomas are invariably wild type. Other lesions in the differential diagnosis include ductal papillomas as well as adenomyopitheliomas, again, both of which have both epithelial and myoepithelial elements. And both of these tumors can have focal chondromyxoid stroma. In fact, these lesions may, in fact, just represent a spectrum of disease and may not, in all cases, necessarily be separate entities and can be difficult to distinguish from one another. But in general, the presence of diffuse chondromyxoid stroma would favor pleomorphic adenoma. These tumors, of course, are benign. They're treated by excision to negative margins. There are rare reports of recurrences, but this may be related to incomplete excision. And as in the salivary gland, and occasionally these tumors can undergo malignant transformation, but it appears to be much less common in the breast than in the salivary gland. So far, 5 such tumors have been reported in the literature, and these were described as being matrix-producing metaplastic carcinomas or hydrate triple-negative breast cancers. So moving on then to salivary gland-like carcinomas. Secretory carcinoma was first described in detail by McDivitt and Stewart in 1966, and they termed these tumors juvenile carcinomas as they were identified in children, but we now know that these tumors, in fact, are more common in adults with a mean age of 53 years. And like secretory carcinomas in the salivary gland and other sites like the skin, they have a very characteristic histology and have a similar genetic underpinning, being that of an ETV6 and TREC3 fusion that is typical for these carcinomas. In the breast, they typically present nondescriptively as a slow-growing, firm, painless mass. On imaging, some cases can be circumscribed and mimic benign lesions like a fibroadenoma, and typically present at low stage with a mean tumor size of about 2 centimeters across the board. This shows the characteristic histomorphology of secretory carcinomas. These cells are polygonal. They have ample vacuolated cytoplasm. You can see the characteristic eosinophilic secretory material, which is both extracellular and intracellular and can be highlighted by PAS stain. The nuclei of these tumors are typically low grade or to intermediate grade, round to oval. They characteristically have these very distinct small nucleoli. There should be no mitotic activity, and overall, these tumors are generally Nottingham grade 1 or 2. Here is a typical image low power of a secretory carcinoma. You can see these anastomosing nested areas in this very characteristic fibrotic to sclerotic stroma. And even at this power, you can appreciate the very dominant microcystic growth pattern that's so typical of these tumors, seen here again on a little bit higher power with the prominent extracellular secretions. Most tumors do have a dominant microcystic growth pattern, but you can see a variety of other patterns. Papillary has been described, tubular patterns, solid patterns. Most tumors do have some combination of a mixed growth pattern. By immunohistochemistry, these tumors have a very characteristic profile, but it's not specific. They tend to express SOX10, S100, mammoglobin, and MUC4, usually in a very strong and diffuse pattern, which I think is very helpful. TRPS1 is usually positive, but other breast markers like GATA3 and GCFP15 tend to be more focal or patchy in these tumors. Like the other salivary gland-like carcinomas, that by immunohistochemistry, they do have the so-called basal-like immunoprofile, being CK56 positive, and again, in most cases, being ER negative, although ER positive tumors are not necessarily that infrequent. In fact, if you look across the studies that have been published, in some series, up to 50% of the cases have been shown to be ER positive. Most of the time, these cases are low positive, meaning less than 10% of the tumor cells are positive, usually with weak to moderate staining. But we've certainly seen tumors with more ER positivity than that, and that wouldn't necessarily exclude the diagnosis. These tumors are, again, underpinned by a fusion protein between the dimerization domain of a transcription factor called ETV6 and the tyrosine kinase domain of the neurotrophic tyrosine receptor kinase, NTRK3 or TRK-C. This creates the chimeric protein kinase that aberrantly localizes to the nucleus, where it can drive oncogenesis. And we can, of course, identify these fusions using an ETV6 break-apart probe, FISH, as well as NGS-based assays. Now, these fusions were first identified in infantile fibrosarcomas and congenital mesoblastic nephromas, and since then have been identified not just in secretory carcinomas of various sites, but also in other carcinomas such as papillary thyroid and colon carcinomas, and in fact, tumors of various different lineages. But in the breast, these fusions do appear to be highly specific for secretory carcinoma. And in fact, they're also highly sensitive for secretory carcinoma. In those published studies in which molecular analysis was done, so far over 90% of these tumors have either ETV6 rearrangement by FISH or have been shown to have the fusion directly. Now, importantly, alternate fusions that have been found in salivary gland secretory carcinomas, either involving ETV6 or involving other genes, have so far not been identified in the breast. Although I'll note that there are very rare reports of NTRK1 fusions that have been reported in tumors that were diagnosed as secretory carcinomas. Unfortunately, in this particular publication, those tumors were not additionally characterized or described. In any case, if there are alternate fusions involving NTRK3 or any other NTRK genes, these are expected to be exceedingly rare in breast secretory carcinomas. This is a study we did a few years ago in which we sequenced a series of breast and salivary gland secretory carcinomas by targeted sequencing using a large cancer gene panel. And we found that the ETV6 NTRK3 fusion was, in fact, the only genetic driver in these tumors. It was an early event, present also in carcinoma in situ, and we found no additional pathogenic driving mutations. Overall, the mutational burden was low, including the other bystander mutations, and there were few copy number changes. And so I think this really highlighted the fact that fusions, as might be expected, are the key drivers of these tumor types and are not necessarily required to have other cancer gene drivers, at least not common cancer genes. Now, given that the fusion does cause aberrant localization in the nucleus of the chimeric TRK protein, this can be harnessed using immunohistochemistry in order to be used as a diagnostic aid. So this is a study from years ago where 20 secretory carcinomas were stained with an antibody that detects all three of the TRK proteins. And as you can see, 23 of the 24 tumors were positive, meaning that they showed exclusively or primarily nuclear staining. There was only one negative case, and this was a core biopsy with very limited material. And importantly, non-secretory carcinomas included in the study, of which there were 203, only about 10% of them showed any nuclear staining, but this was weak, focal, and barely perceptible, not really in the range that you would see in the secretory carcinomas. And importantly, all histologic mimics were negative. And so this is a marker that's very useful, I think, in the proper diagnostic context to make the diagnosis. It's highly sensitive, specific, and we use it routinely. This is a more recent study also looking at TRK expression in breast and salivary gland secretory carcinomas. This study included 14 tumors. All of them were positive with a cutoff of at least 10% nuclear staining of moderate to strong intensity. And in this particular study, none of the 338 non-secretory carcinomas showed a similar level of staining. And so, again, a very highly sensitive and specific and useful marker. The differential diagnosis of secretory carcinoma is pretty broad. It includes a number of other salivary gland-like carcinomas we'll discuss in this lecture, including actinic cell carcinoma and mucoepidermoid carcinoma, but also other tumors like tall cell carcinoma with reverse polarity, carcinoma with apocrine differentiation. Sometimes invasive breast cancers of a special type can mimic secretory carcinoma, and even benign lesions with secretory type features. So here's an example on the left of a tall cell carcinoma with reverse polarity. This particular tumor had a very prominent microcystic growth pattern. You can see the extracellular secretions, very closely mimicking what you might see in a secretory carcinoma. But of course, secretory carcinoma lack that characteristic reverse nuclear polarity that is typical of tall cell carcinomas with reverse polarity. And in challenging cases, immunohistochemistry can be very useful. Secretory carcinomas being strongly positive markers like S100 and pan-TRK, which would be negative or at most focal in TCCRP. Apocrine carcinomas can sometimes mimic secretory carcinomas given their eosinophilic cytoplasm and vacuolization, sometimes with focally microcystic growth pattern and extracellular secretion. But of course, apocrine carcinomas are strongly and diffusely positive for markers like AR and GCDFP15, which is not seen in secretory carcinomas. This is an example of an IDC with a very prominent cytoplasmic vacuolization, but this tumor was very strongly ER and PR positive, but I think was a very good mimic of secretory carcinoma. It's important to recognize these tumors and distinguish them from conventional triple-negative breast cancers because they have an excellent prognosis, even when they present with no metastasis, which is seen even in about 30% of these cases. In population-based studies, such as the SEER data, you can see that 10-year breast cancer-specific survival was 93%. So excellent prognosis compared to other triple-negative breast cancers. In terms of treatment, radiation is being increasingly used for these patients, especially in adults. And in terms of chemotherapy, there's certainly limited data, but really it shouldn't be considered based on only the triple-negative status of these tumors. Could be considered in node-positive tumors, but certainly neoadjuvant chemotherapy is contraindicated in contrast to conventional triple-negative breast cancers. Having said that, rare tumors can be aggressive and show distant metastasis. If you look at the rare tumors that have been published in the literature, they tend to be larger than the non-metastatic tumors with a mean size of 5.5 centimeters. And those that have been analyzed molecularly tend to have additional genetic changes, including in several cases CKN2A loss. This is the tumor suppressor P16, as well as mutations in TERT promoter, suggesting that these additional genetic changes in the tumors may help drive that more aggressive phenotype. When they do metastasize, these patients tend to have poor prognosis. The metastatic tumors are often chemo-resistant, but these patients are candidates for FDA-approved TRK inhibitor therapies such as larotrectinib, entrectinib, and repotrectinib, which have shown to be efficacy in NTRK rearranged tumors in general, including secretory carcinomas. Adenoid cystic carcinomas tend to present in older postmenopausal women with a mean age of 64 years. These tumors are usually subareolar in location, usually present as a palpable mass, and like adenoid cystic carcinomas elsewhere, are composed of dual epithelial and myoepithelial cell populations and are driven by MIB activation in most cases due to a characteristic fusion between MIB and the NFIB gene. In the breast, we recognize 3 variants of adenoid cystic carcinomas according to the WHO. The most common is the classic pattern, rarely solid basaloid pattern adenoid cystic carcinomas, which are more aggressive. And in the breast, very exceedingly rarely, these tumors can show high-grade transformation to other invasive cancer types, but this is probably much less likely in the breast than it is in the salivary gland. Classic adenoid cystic carcinomas have a variety of growth patterns. The most common is cribriform, but they can also show tubular growth, solid growth, and in many cases, a mixed growth pattern. Importantly, these tumors should lack marked nuclear atypia or necrosis, and mitotic activity is usually low. And so when these criteria are met, they generally have indolent clinical behavior. Here's an adenoid cystic carcinoma with a prominent cribriform growth pattern, which is manifest as areas of more solid cribriform-like growth, trabeculae cribriform cells, as well as areas with circumscribed nests. Notice here there's an area of perineural invasion. This can be seen in the breast and adenoid cystic carcinomas, probably less common than it is in the salivary gland, where it's a very distinctive feature of these tumors. Classically, these tumors, of course, are recognized as having dual cell populations. The more dominant cell type are the myoepithelial cells. These are abluminal and line these pseudoluminal spaces, which generally have eosinophilic hyaline or myxoid basement membrane-like material that can be highlighted by PAS or basement membrane stains. And less dominant are the epithelial cells that line the true lumens, highlighted here by an asterisk. Generally, these cells are more eosinophilic and have slightly larger nuclei, and these spaces may or may not have secretions. In some cases, the basement membrane material can be very prominent and can compress the epithelial, myopithelial proliferation into these thin interconnected strands, giving this reticular pattern. Now, we usually think of these tumors as having biphasic differentiation, but I think it's useful to remember that they're probably not truly lineage restricted and probably better to be thought of as epithelial-like and myoepithelial-like because they do demonstrate in many cases an aberrant immunophenotype, especially for myoepithelial markers. The myoepithelial cells almost invariably will be p63 positive and will express SOX10, but they're often negative for at least one myoepithelial cell marker. Oftentimes this is SMM or calponin, sometimes also SMA. And these are the cells that overexpress the MIB protein. Epithelial cells are positive for low molecular weight keratins like CK7 and CK8, can also be SOX10 positive, and these are the cells that are CD117 positive, although, of course, this marker is not specific for adenoid cystic carcinoma. Most of these tumors, like other salivary gland-like carcinomas, are triple negative, but again, ER-low positive tumors can be found that would not exclude the diagnosis. And like the other salivary gland-like carcinomas, these tumors can express CK5-6. So here's a classic adenoid cystic carcinoma showing that typical immunophenotype. Along the top, we see the epithelial cells lining the true spaces positive for CK7 and CD117, whereas along the bottom, the pseudoluminal spaces lined by P63 positive and SMA positive myoepithelial cells. In this particular case, the tumor has lost expression of SMM. This is an example of a classic adenoid cystic carcinoma with a tubular growth pattern. I think you can very easily imagine that this can be mistaken for benign proliferation and adenosis, or perhaps a radial sclerosing lesion, given these relatively bland tubular structures lined by both epithelial and myoepithelial cells. You can see on the P63 stain, oftentimes the P63 is peripheral, as you would expect in a benign proliferation. This highlights how important it is to use, again, multiple myoepithelial cell markers when you're evaluating these lesions. You can see here in this particular case, calponin was completely negative, inconsistent with a benign proliferation, and ER can also be helpful, being negative in adenoid cystic carcinoma and positive in sclerosing lesions and adenoses. As already mentioned, most of these tumors, when they're classic, are underpinned by the MYB-NFIB fusion gene, as they are in other sites. But this is not universal. Alternate rearrangements have been described in a related gene called MYB-L1. Also, some tumors have MYB amplification instead of rearrangement. And the rearrangements can be detected by MYB-FISH or by NGS-based assays, which can help in challenging cases make the diagnosis. In all these cases, the MYB aberrations are thought to cause upregulation of the MYB oncoprotein, and this can be detected by both IHC and by RNA in situ hybridization. Aside from the fusion protein, these tumors in classic tend to have a low mutation burden, again suggesting that the fusion is the main of adenoid cystic carcinoma depends very heavily on the growth pattern. Cribriform tumors should be distinguished from both invasive and in situ ductal carcinomas. This is relatively easily accomplished by immunohistochemistry because ductal carcinomas, of course, are luminal tumors that are strongly ER positive and CK5/6 negative, which is the opposite immunophenotype of an adenoid cystic carcinoma. When superficial cutaneous tumors enter into the differential, such as cylindromas and spiradenomas, and in some cases, especially on limited material, you can even consider collagenous spherulosis in the differential diagnosis. Collagenous spherulosis is usually, of course, incidental or can be the target of calcifications, but sometimes can involve pre-existing lesions. Here's some examples of collagenous spherulosis involving a papilloma and a radial scar, and you can imagine that this very much, especially on limited material, could mimic an adenoid cystic carcinoma. In challenging cases, immunohistochemistry can be very useful. Collagenous spherulosis retains a full complement of myoepithelial cell markers and also is ER patchy positive, whereas adenoid cystic carcinoma, again, often loses at least one myoepithelial cell marker or shows aberrant staining, and these tumors are typically ER negative. The tubular pattern, again, can be very challenging to differentiate from radial sclerosing lesions or adenosis, as I've just shown you an example. Again, here a panel of myoepithelial cell markers as well as ER can be very helpful. Also in the differential would be tubular carcinomas and microglandular adenosis, but these proliferations are comprised only of epithelial cells, and of course tubular carcinomas are strongly ER positive, and microglandular adenosis is strongly S100 positive. Low-grade adenosquamous carcinoma can also mimic tubular pattern adenoid cystic carcinoma, but the squamous nests of these tumors or the desmoplastic inflammatory stroma that's so characteristic of low-grade adenosquamous carcinoma is not typically a feature of adenoid cystic carcinoma. And a really helpful clue is that most of the time the tubular pattern is in fact not pure, and it's associated locally with cribriform growth. Now, that's classic adenoid cystic carcinoma, should be distinguished from a less common variant, solid basaloid variant, because these tumors are known to be more aggressive. Solid basaloid adenoid cystic carcinoma is characterized by solid nests, trabeculae, and even rare glands of tumor cells with basaloid features, meaning they have increased NC ratios, typically more nuclear pleomorphism. Mitotic activity can also be increased in these tumors. And they're typically set in this very characteristic myxoid or hyalinized stroma, which is often a very helpful histologic clue. Importantly, the dual epithelial myoepithelial differentiation of classic adenoid cystic carcinoma is less conspicuous, almost by definition in these tumors. Sometimes you can see small intercalated duct-like structures, and that can be very helpful to help the diagnosis. Oftentimes, there's also an in situ component that has similar morphologic features. And as I already mentioned, these tumors tend to be higher grade due to increased pleomorphism and higher mitotic activity. But here we see the typical growth pattern of a solid basaloid adenoid cystic carcinoma, showing these large solid basaloid nests of tumor cells in this very characteristic appearing hyaline to blue myxoid stroma. Some cases, the tumor nests can be smaller and can be trabecular, and you can see even rare gland-like formation. But again, notice this characteristic hyaline and especially blue myxoid stroma. That's very characteristic. Also notice here the component of PCIS at the edge. A very helpful histologic clue for this particular variant is if you can identify areas of eosinophilic basement membrane-like material that can be embedded within the basaloid tumor cell nests. So this can be a surrogate for, myoepithelial-like differentiation and functionality in these tumors and can be very helpful. Also, as seen on the right, another very helpful feature is the presence of these small intercalated duct-like structures that can be embedded within the basaloid tumor cells, although sometimes these are very focal, and we've seen cases where only the metastasis has these duct-like structures and they weren't present in the primary tumor. Immunohistochemistry can sometimes be very helpful to help identify these structures, although the immunophenotype is not consistent. They are usually positive for low molecular weight keratin CAM.5, CAM5.2, as well as CK5-6, but CK7 can sometimes be positive and can sometimes be negative, and so this marker is less helpful. Other markers that are typically positive are CK7, SOX10, Z117, positive in the basaloid tumor cells, usually diffusely positive, whereas markers like GATA3 or P63 are generally negative. Sometimes you can have focal or weak GATA staining or focal P63 staining that sometimes is present at the periphery of the nests. Most of these tumors will be triple negative. We have seen cases that are ER low positive, and the Ki-67 index, as expected, is high. In differential diagnosis for these tumors, most challenging is a high-grade triple-negative breast cancer with basaloid features. This is a recurrent diagnostic issue that we struggle with almost every time we see one of these cases, it seems. Other lesions in the differential are, of course, poorly differentiated neuroendocrine carcinomas and Merkel cell carcinomas, which can be resolved using neuroendocrine marker immunohistochemistry, as well as lymphoma. But here, this is the most common diagnostic problem, how to differentiate these tumors from triple-negative breast cancers with basaloid features. Of course, if you do see the intercalated ducts, the myxoid characteristic stroma, or especially basement membrane material, that can certainly point to the diagnosis of solid basaloid adenoid cystic carcinoma. These tumors often are also immune poor in contrast to other high-grade triple-negative breast cancers that can have a more prominent TIL infiltrate. And one marker that we and others have found to be very useful is MIB in this context. So in contrast to classic adenoid cystic carcinomas, these tumors very infrequently actually have the classic MIB NFIB fusion, which has been reported in only up to about 20% of cases. They do often, interestingly, have other alternate MIB alterations, including rearrangements with other so far unknown fusion partners, and in some cases MIB copy gain or amplification. But more importantly, in all of these cases, they do tend to show MIB overexpression, which can be assayed by both immunohistochemistry as well as by RNA in situ hybridization. And we find that to be very useful diagnostically. This is a study we did a couple of years ago, a series of solid basaloid adenoid cystic carcinomas, where we looked at MIB expression by either immunohistochemistry or RNA in situ hybridization and compared that to MIB rearrangements detected by either NGS and or FISH. And you can see here in the red and maroon boxes, in all of the tumors with a signal that can be evaluated, all of the tumors did show overexpression by either IHC or RNA in situ hybridization for MIB, and this correlated with the green and blue boxes, which is MIB copy gain amplification or rearrangements by genetic methods. This has also been shown by a number of other groups. Batra et al. Most recently looked at a series of 17 solid basaloid adenocarcinomas using a cutoff of 75% positive staining, which was strong. All of their tumors were positive, and importantly, in terms of specificity, no metaplastic carcinomas and no other triple-negative breast cancers were positive. A slightly older study by Massa et al. From 2020 using IHC H-score methodology of at least 150 found 82% of their solid basaloid adenoid cystic carcinomas to be positive. And they did have some triple-negative breast cancers that were positive, but these all showed focal weak staining. So we find this marker to be very helpful in this differential diagnosis in particular, although I will note that in our hands, at least, it appears to be more reliable on core biopsy than on excision specimens, which may be related to the short half-life of the protein in combination with increased fixation times in excision specimens. So we also always make sure to look for lymphocytes as internal control before we evaluate a tumor as being negative. And in addition to MIB alterations in terms of genetics, these tumors do have a very characteristic profile, although it's certainly not specific. They tend to have very frequent Notch pathway aberrations, including mutations in both Notch1 and Notch2 and other genes in the pathway. Mutations in chromatin modifiers, such as especially CREBP. They less frequently have p53 mutations than other high-grade triple-negative breast cancers, and also tend to have simpler genomes, except for those tumors that are p53 mutated. And so this is not a very specific genetic profile, but it's certainly characteristic and can be also very helpful in the differential, especially with that differential with other high-grade triple-negative breast cancers. In terms of clinical outcomes, a histologic subtype is considered a very useful prognostic indicator. As I've already mentioned, classic adenoid cystic carcinomas in the breast have a very favorable behavior usually. This is the most common subtype that is included in large cohorts and population-based studies, such as the database and the National Cancer Database, and overall 10-year survival here has been shown to be very high at 95%. These tumors do tend to occur, present at early stage, have infrequent nodal and distant metastasis, typically are treated with surgical excision with or without radiation therapy, and usually a sentinel node is also obtained. In contrast, solid basaloid adenoid cystic carcinomas, as I've already mentioned, are more aggressive. They more frequently have nodal and distant metastases. And these tumors are accordingly more often treated with chemotherapy. And given the high frequency of Notch pathway aberrations, patients can also be in trials potential candidates for targeted therapies with Notch inhibitors, which have been used in the head and neck adenoid cystic carcinomas, especially those aggressive tumors with solid growth pattern. This is some data from two studies looking at solid basaloid adenoid cystic carcinomas defined as at least 90% of the tumors showing solid basaloid morphology. And you can see here how aggressive these tumors are. They're more often grade 3. They frequently have LVI and lymph node metastasis. Up to 30% of these tumors in these studies showed local recurrence. Up to 65% showed distant metastasis, and this included tumors that presented with de novo metastasis, and they had a pretty bad disease-specific survival, certainly in comparison to classic adenoid cystic carcinomas. So these are very aggressive tumors, probably more in line with other high-grade triple-negative breast cancers, certainly much worse than classic adenoid cystic carcinomas. On the other hand, they have poor responses to neoadjuvant chemotherapy and the very limited data that's currently available. Aside from one case that's been reported in the literature, the responses have been pretty poor. These are two very excellent studies on other clinical outcomes in breast adenoid cystic carcinomas. And interestingly enough, if you look at the predictors of outcome in these two studies, they are remarkably similar, highlighted here in purple. And some of the most important, I think, outcome predictors in both of these studies are the basaloid component and solid growth pattern, which was found to be predictive in both cases, as well as Nottingham grade, especially grade 3 versus grade 1 tumors. The second study also evaluated new grading system in addition to the Nottingham grade, which included the percent of solid growth, whether or not there was basaloid morphology, as well as mitotic activity, and this was found to be predictive. And so again, highlighting how important solid basaloid components in these tumors are, as well as the features that go along with that solid basaloid phenotype in terms of predicting outcome. All right, mucoepidermoid carcinomas. Interestingly enough, these are the most common malignancies in the salivary gland. The parotid gland are, however, exceedingly rare in the breast. But like in the salivary gland, they have a very characteristic phenotype, very characteristic histology, and also share the same genetic underpinnings with their salivary gland counterparts. In the breast, they typically present in women with a mean age of 54 years, can be identified on screening, but probably more often as a palpable nodule, sometimes as nipple discharge. And these tumors sometimes can be cystic, also on imaging, or can be circumscribed. And in fact, on histology, they are often at least partially cystic, as you can see here, and very characteristically usually are associated with a prominent lymphocytic infiltrate at the periphery. Here's an area of more solid type growth. They typically have this microcystic growth pattern also, and you can see this tumor has some solid papillary-like features as well. Usually there's some component of infiltrative growth with either solid or microcystic pattern infiltration into the tissue. Here's another higher power image of microcystic growth. It's typical of these tumors, and you can see it's so prominent extracellular secretions that are either eosinophilic or a little bit more mucus and mucinoid. Also, the stroma is very characteristic of the tumors, being often kind of this sclerotic to hyalinized matrix. Like in other sites, these tumors are comprised of multiple cell types. The basaloid or intermediate cells tend to be present at the periphery of the tumor cell nests. These cells have a high NC ratio, tend to be more hyperchromatic and basaloid. The epidermoid and squamoid cells have more voluminous cytoplasm. These can show squamoid changes present both peripherally and centrally. And then the mucinous cells, which have mucinous cytoplasm. Importantly, true keratinization should not be seen in these tumors. Here's another mucoepidermoid carcinoma showing again a dominance of basaloid intermediate cells, epidermoid cells. One feature in the breast is that the mucinous cells are often relatively scant and difficult to identify, even in low-grade tumors. Some of these tumors can show clear cell change, which you can see here. And by immunohistochemistry, these various cell types can be highlighted by different keratins. The basaloid and intermediate, as well as epidermoid cells, often are positive for high molecular weight keratins, as well as p63, whereas the mucinous cells are more often positive for low molecular weight keratins and can also be, in some cases, highlighted with mucin stains. Now, in contrast, p63 myoepithelial markers are negative, so this tumor doesn't have myoepithelial differentiation. Other markers that have been shown to be POX10 and MUC4, as well as mammoglobin, but so far a limited number of tumors have been evaluated with these markers. This differential staining pattern can create a very characteristic zoning expression pattern that can also be seen in the breast, where high molecular weight keratins and p63 tend to be positive at the periphery of the tumor nests, where the basaloid and intermediate cells are, whereas CK7 often spares the periphery and is more positive centrally. As already mentioned, these tumors are underpinned by characteristic fusions. These involve two genes, most commonly CRTC1, less commonly CRTC3, fused to the MAML2 gene. This has been identified in low and intermediate grade mucoepidermoid carcinomas, as well as hydroadenomas, which also share these same fusion genes. This creates an oncogenic transcriptional coactivator, which has transforming activity and can be detected by both FISH and by NGS-based assays. Like the other salivary gland-like carcinomas underpinned by gene fusions, otherwise the genomes tend to be pretty quiet. There's only been one other pathogenic mutation so far identified in a low-grade mucoepidermoid carcinoma, although I would say that very few of these tumors have so far been analyzed molecularly. And so far, there's been only molecular analysis of 2 high-grade tumors, none of which showed MAML2 rearrangements. So this is something you see most commonly likely in lower intermediate grade tumors, which again mirrors what is seen also for the salivary gland. Now, as opposed to adenoid cystic carcinomas, secretory carcinomas, where we have immunohistochemical surrogates, this has not yet been identified for mucoepidermoid carcinoma, but this is a very nice study by Gregor Krings published this year, where instead of immunohistochemistry, they use chromogenic RNA in situ hybridization probes as surrogates for the diagnostic fusions. And they looked at a series of breast and salivary gland mucoepidermoid carcinomas, breast and cutaneous hydradenomas, which again share the same fusion genes, as well as a number of histologic mimics, and found a breakpoint-specific probe for either CRTC1 MAML2 or CRTC3 MAML2 was found to be highly sensitive and specific for MAML2 rearrangements in these tumors. And similarly, they also looked at a long non-coding RNA, link473, which is known to be downstream of the CRTC1 MAML2 fusion protein, and also found that this expression, the expression of this long non-coding RNA was also highly sensitive and specific for this rearrangement. And so I think this is a very nice study. It highlights the potential use of these markers as the very timely diagnostic surrogates to look at these gene fusions as diagnostic aids using light microscopy and not requiring other molecular tools. The differential diagnosis of mucoepidermoid carcinoma is quite broad. It can include both benign lesions that are listed here on the left, as well as malignant lesions shown here on the right. In most cases, these can be relatively easily distinguished from one another if you can recognize the different cell types in mucoepidermoid carcinomas and also the distinctive immunophenotype, with these tumors being CK56, P63 positive, and ER negative, which is a very unusual immunoprofile in breast cancers. One of the more challenging differentials is to differentiate mucoepidermoid carcinoma from hydradenomas. Again, these tumors share a similar morphology. They also share the same genetic underpinnings. And so these can be very challenging to differentiate from one another. Some features that can be helpful is mucoepidermoid carcinomas often tend to be more intraparenchymal and present as irregular infiltrative nests. And if there's an in situ carcinoma component present, that can be very helpful. Whereas hydradenomas often, but not always, are more superficial. They're typically tend to be more circumscribed and solitary. And they oftentimes also have a minor component of small ER-positive glandular structures that are not present in mucoepidermoid carcinomas. Very important differential consideration is metaplastic carcinoma, especially with squamous differentiation. Again, true keratinization should never be seen in mucoepidermoid carcinoma and essentially excludes that diagnosis. And of course, if you can identify the different cell types, that can be very helpful. Some mucoepidermoid carcinomas, again, will mimic other salivary gland-like tumors. Here, this one mimicking secretory carcinoma due to the very prominent microcystic growth pattern and extracellular secretions. But again, immunohistochemistry can relatively easily distinguish these lesions. Sometimes, especially when showing clear cell change, these tumors can mimic adenomyopatheliomas, as seen here. Both of these tumors will be P63 positive, but because mucoepidermoid carcinomas don't have myoepithelial differentiation, they'll be negative for other myoepithelial markers, and that can usually help make the diagnosis in these cases. In terms of clinical outcome, this is very highly dependent on the histologic grade of mucoepidermoid carcinoma as well as stage. And it's been shown a number of years ago that both salivary gland and Nottingham grading systems are interchangeable in this context. Shown here in the white box, some data from a recent literature review looking at outcomes of mucoepidermoid carcinomas, and it was found that low-grade tumors had a lymph node metastasis of only 9% compared to 47% of high-grade tumors, and none of the patients with low or intermediate-grade mucoepidermoid carcinomas died of their disease, compared to 42% of patients with high-grade tumors. And so this really highlights the importance of viewing these tumors and the importance that has for clinical outcome. There are no established guidelines for treating these very rare tumors. Typically, they are completely excised surgically. There's limited data on sentinel node or radiation therapy. But I think it's safe to say that low-grade tumors certainly should not be treated with chemotherapy. Okay, the last tumor that I want to mention is a actinic cell-like carcinoma. Again, also may be referred to this as breast carcinoma resembling actinic cell carcinoma. These are very rare tumors. Less than 80 have been reported in the literature, and they're characterized by serous acinar differentiation. I've already alluded to the fact that tumors morphologically resemble salivary gland actinic cell carcinomas, but are genetically distinct, so are likely to be different tumors. In the breast, they typically present in adult women. Only one male has so far been reported. These tumors are defined by cytologic features of serous acinar differentiation, which I'll show you some examples of. This is granular eosinophilic or amphiphilic, and sometimes clear cytoplasm. These tumor cells tend to have round to oval, centrally placed nuclei. Atypia can be variable, and mitotic activity can be variable as well. The common growth patterns are acinar, microglandular, and solid, but rare tumors can also show areas of trabecular growth, even single cells, and papillary growth, but these are usually mixed with the more common acinar or microacinar patterns. Interestingly enough, actinic cell-like carcinomas in the breast show a very close association with microglandular adenosis, and this is often difficult even to distinguish atypical microglandular adenosis from actinic cell-like carcinoma. And in fact, some have considered that these tumors are not actually a distinct entity, but are just invasive carcinomas arising in a background of MGA. Nonetheless, DCIS with similar features is often seen, or is at least in some cases seen in these tumors. And they can be pure actinic cell-like, or they can be mixed with other types of invasive carcinoma. Typically, this is high-grade triple-negative breast cancer or metaplastic carcinoma. So here's an example of an actinic cell-like carcinoma at low power. You can see the various growth patterns, microglandular, as well as acinar growth, as well as areas of sheet-like solid growth in this particular case. And on higher power, we see that characteristic evidence of serous acinar differentiation with very granulated cytoplasm showing Paneth cell-like granules in these cells. The granules in some cases can be fine, some cases they can be more focal. Often they're at least focally coarse and Paneth cell-like, as is seen here. And in some cases they can be very inconspicuous, as you can see here in the bottom left, and this, of course, make the diagnosis much more challenging. Some cases can have clear cell change with or without granules, and if the granules are present, they can be highlighted with PASD. Here's some examples of the different growth patterns at a little bit higher magnification. Microglandular, sometimes having colloid-like secretions in the lumens. Acinar growth is very common, sometimes nests. This is a case here showing very prominent, at least focally, still cell growth, but you can see the serous acinar differentiation on higher power. And in some cases, you can even see trabecular growth as seen here on the right. These tumors often have a prominent lymphocytic infiltrate associated with them. This can be very helpful in distinguishing them from atypical microglandular adenosis, which doesn't typically have this feature. And by immunohistochemistry, they express serous acinar markers, at least patchy, often diffuse positivity for lysozyme, amylase, as well as alpha-1 anti-chymotrypsin. Other markers that can be positive are SOX10 and S100, as well as EMA. Again, most of these tumors are triple negative, but some cases can be ER low positive. And P53 can also be very helpful. It's often aberrant because P53 is often mutated in these tumors. Here's an example of an actinic cell-like carcinoma mixed with a high-grade triple negative breast cancer. And here's another example on core biopsy showing an area of well-differentiated actinic cell-like growth. And in another area of the biopsy, there's a high-grade triple negative breast cancer with necrosis. Now, as opposed to the other salivary gland-like tumors we've talked about, these tumors, again, are genetically distinct from their salivary gland-like counterparts. In the salivary gland, actinic cell carcinoma is characterized by recurrent rearrangements of a gene called NR4A3, sometimes other genes that are related. And this leads to overexpression of the protein, which in the salivary gland, highly sensitive and specific for this diagnosis. But in the breasts, so far of the tumors that have been analyzed, these rearrangements have not been identified, and IHC has been negative for the NR4A3 protein. Also in the salivary gland, these tumors tend to have simple genomes with infrequent P53 mutations, and this is in contrast to the breast, where these tumors often have complex genomes and very frequently have P53 mutations. And so they much more closely mirror other high-grade triple-negative breast cancers than salivary gland actinic cell carcinomas. One very difficult differential is distinguishing actinic cell-like carcinoma from a typical MGA, especially on core biopsy. This can be very challenging given the significant amount of morphologic and immunophenotypic overlap between these lesions. And in fact, actinic cell-like carcinomas, again, often are associated with atypical MGA-like areas, as you can see here on the left, suggesting that these lesions may in fact arise from MGA. And in fact, genetically, it's been shown that carcinoma-associated MGA and actinic cell-like carcinomas are genetically very similar, in particular having frequent P53 mutations. And so this may in fact represent a biologic spectrum of triple-negative low-grade neoplasia from MGA all the way through actinic cell-like carcinoma. But again, others have interpreted this data differently, suggesting that this just shows that these are just invasive carcinomas arising in the background of MGA. Regardless, from a practical perspective, if you do encounter an actinic cell-like carcinoma with MGA or atypical MGA-like areas, it's best to consider those areas as part of the carcinomatous process and to excise the entire lesion to negative margins in order to help prevent recurrence. The differential diagnosis includes a number of other tumors that can have granular cytoplasm, which are listed here, other salivary gland-like carcinomas, especially secretory carcinoma, apocrine carcinoma, neuroendocrine tumors, even granular cell tumors. But generally, immunohistochemistry can relatively simply distinguish among these lesions. In terms of clinical behavior, there's, again, very limited data. There's limited clinical experience with these tumors. From a recent meta-analysis, 23% of tumors were found to have lymph node metastasis, 8% distant metastasis, and 5% of patients died of disease. Although I will note that this data may be a little bit skewed because these tumors that were more aggressive all had either high-grade features or were associated with carcinomas that were high-grade, which may skew the data significantly in that direction. In fact, pure low-grade tumors are much more likely to be indolent. And so there are no currently established management guidelines for these tumors. Usually clinicians use guidelines for other breast cancers. I think it is probably safe to avoid neoadjuvant chemotherapy in cases that are pure and low grade. So in summary then, for salivary gland-like tumors of the breast, these tumors are very diverse. They have morphologic and immunophenotypic and genetic overlap with their counterparts in the salivary gland, again, with the exception of actinic cell-like carcinoma. Salivary gland-like carcinomas have unique characteristics in the spectrum of triple-negative breast cancers, most of the time having generally indolent clinical behavior. It's important to recognize these lesions for patient management. especially to avoid overtreatment for those tumors that are indolent, but also to recognize those rare tumors that are more aggressive and will need more aggressive treatment. These tumors have characteristic morphologic and genetic alterations, and now we also have, for a number of them, immunohistochemical surrogates that can have practical application for an accurate diagnosis, and in some cases may also help point to the use of emerging therapies for those rare cases that are high grade or that have more aggressive behavior. And these are my references. Thank you very much.